Thank you, Chairman. First of all, I would like to thank you for the organization committee for this kind invitation, and I must say that it's a great honor to be here. I know that this is a great step to bring people in all over the Gulf region together and organize such a big meeting. And my name is Şenay. I am from Istanbul. I will talk about the robotic mitral valve surgery today. First of all, my opponent is a great friend, and I believe in endoscopic surgery. And I must say that the endoscopic techniques is the way to go, but robot is a useful tool for these techniques. This picture comes from 2009, and this is me observing a case, a robotic case, in East Carolina University with Dr. Chitwood's team. So it's been nearly 15 years for performing the robotic mitral valve surgery, but during that period it evolved very much. The techniques, the technology changed a lot. And at the end of the journey today, I can say that maybe the robot is one of the best tools for doing an endoscopic surgery, especially in complex cases. So I would like to mention about this issue in my talks. So first of all, total endoscopic mitral valve surgery is basically involving manually controlled long instruments and enable 3D visualization, and is usually done with a very small thoracotomy. This picture is the upper one comes from a publication from Dr. Van Herman's group. And this is one of the classical setups for using in the total endoscopic mitral valve surgery. And below is one of our setups for doing a mitral valve repair. We have a couple of setups for mitral valve surgery, and this is one is used for especially for the mitral repair with a partial ring and also the AST closures. So robotic technique utilizes robotic systems offering telemanipulated instruments actually. It also enables 3D visualization with an HD quality. And I must say that enhanced precision is one of the biggest advantage over the classical endoscopic technique. But the shared goal of both techniques is achieving a minimally invasive, effective mitral valve repair or replacement. So this is the important point. I mean, the important point is the patient, not the technique that you use. And both is available and both is there and both is effective. But there may be some kind of small changes. This is an example from a re-operation, I mean re-repair of a patient who was operated around 10 years ago in another center. And I must say that in the classical endoscopic setup, we have the rigid tools, the long tools, which may limit the maneuverability in two-dimensional plane because there is no wrist angle. Still doable at least for some of us, but maybe not easy. Meanwhile, robotic system can provide 7 degrees of freedom for instruments, mimicking just like the human wrist motion. So as you can see in the beginning of this operation, this specific patient required some kind of precision, I mean, in means of the movement inside the left atrium. First of all, in the first step, we saw the excision of the previous, as you can see, excision of the previous ring implanted there. And this may be not easy, at least in my hands, to do with the long shafted instruments. And meantime, I can say that there is actively 6 instruments inside, 4 by the console surgeon and 2 by the patient side controlled. So, and one more important point is the actively controlled retractor. So you can use the retractor at any point of the heart, inside or even using it outside the heart. For example, just putting a stitch on the cardioplegia needle in the aorta. So I think this maneuverability is a very important point that the robot has an advantage. So there are also some kind of other complex cases like the MAC, which we have discussed yesterday, and we have seen a very nice series of patients from a surgeon from the Saudi. So I know that this kind of patients, at least in some centers, are referred to open surgery So this patient, as you have seen, has a prolapsus in the posterior leaflet and a severe MAC in the posterior annulus. So the primary aim for this operation was the resection of the calcified tissue with robots, and then suturing the leaflet to the annulus. And I must say that this is something that at least not easy for doing with long-shafted instruments in a classical technique. So I believe that these robotic instruments can add some kind of value during this kind of operation. And at the end, you see the sizing of the ring and the implantation of the ring here. We use cornuts as usual, and the water test is somewhat okay, but we don't rely on the water test as much as we can. So this is the postoperative echo, and we will just see the color images and the valves perfectly functioning well. So and another group of patients that may benefit from robotic instruments may be the redo cases. In redo cases, there may be some kind of adhesions of the pericardium and also adhesions of the lungs itself. So robotic instruments can make these kind of adhesions easily be opened during the operation. So usually the portion of the pericardium or the portion of the lungs just in front of the minithoracotomy is not a problem, but when you try to go through the cranially or through the caudally, there may be some kind of a problematic, and in this kind of a setting, the reset instruments may add some kind of a value while doing this kind of an reoperations. So yes, we have seen some kind of complex cases, but is there any relation with the outcomes? I mean, when you do a robotic operation in a complex case, does it differ in means of the outcomes? Yes. There's a recent meta-analysis analyzing a very large group of patients, more than 60,000 from 18 studies, and the result is compared between the conventional non-robotic minimal invasive surgery and robotic surgery. And at the results section, the paper concluded that robotic surgery showed more favorable surgical outcomes, including the hospital stay, postoperative complications, and mortality. So this is something that is very important for the at least group of patients coming from the case studies from all around the world. So and as a result, I can say that yes, it has a value in means of improving the outcomes. So this was case groups analysis, and what about the matched groups? So this paper comes from 2022, and there was a comparison of the matched groups between the endoscopic and robotic cases. There was not significantly different outcomes, but you can see the freedom from moderate to severe mitral insufficiency at 10 years was 73 in the endoscopic group and 86 in the robotic group. This is not statistically significant, but I think it may have some kind of value. And in some kind of limited data from kind of very limited group of patients, especially from the MEA group, the data suggests that the robotic surgery may enable shorter hospital stays, reduced postoperative pain, and a faster return to the normal activities. And it's related with higher patient satisfaction due to improved quality of life post-surgery. So is there any challenge? Yes, of course. The first one is the cost effectiveness, and the second one is the learning period. Regarding to the cost effectiveness, it has some kind of a tricky parameters, but if you work in a high volume center and if you can arrange a robotic program with a multidisciplinary setting, it works. So these patients come from the Dr. Mihalevich group from Cleveland Clinic. They assessed over 1,000 patients with a matched group format. They compared the robotic patients with sternotomy over partial sternotomy or minimal invasive setup. While upfront costs are higher in a robotic setting, reduced post-operative reoperation rates and shorter recovery periods may offer long-term savings in their findings. And also high-volume centers achieve better scalability and standardized outcomes, they say in their paper. And what we apply in our center also is organizing a multidisciplinary approach. I mean, the mostly busy department in our center is the urology, and the second one is general surgery, and the third one is cardiac surgery. In this setting, the cost effectiveness may be established. And the second one is learning period. It's very important. It's also true for the endoscopic setting. So they have there's a new machine, and you have to get familiar to use that. This figure is from our data. We try to figure out after what number of patients we stabilized our cross-clamp times and cardiopulmonary bypass times, and it was around 30 for the mitral repair. The outcome, the results was not different between the replacement patients and the repair patients. It was again 30 for the learning period. And this was published in the Journal of Cardiac Surgery, and in the results section and the conclusion section, we offered that for the initial 30 cases, for achieving a safe learning period, you can just select the patients and go for just simple P2s or maybe replacements in the learning period. So what we can do for establishing a safe learning period, there are some technical skills training. This is the environment of our case laboratory in our university. So we offer some kind of simulation programs preclinically, and then we further move to the cadaver training and mannequin training and animal work. And then we offer some kind of center visits, and then we offer some kind of supervised operations. This center is one of the official training centers in Europe and Middle East, and it's highly busy with the urologists and also the cardiovascular surgeons. And as you can see, that is me giving some lectures to the NEF team who will just launch an robotic program. And also in means of the clinical training, there's an option for dual console. That is me on the right and my colleague in front of me doing a complex mitral valve case for repair. And it's kind of a pathway for training each other. I mean, there's an option for doing the operation together in this kind of setting. Also, this technique, the robotic options, may enable to establish some kind of new techniques during the operation. This is an augmented reality glass, which is suitable for, showing the inside endoscope image to your glasses. And during the operation, you can just focus on the surgical area. On the right side, that is me focusing on the surgical area, and you can see the nurses is just looking at the screen. This kind of new technology can be adapted easily during robotic techniques. As a conclusion, I can say that robot is a useful tool for endoscopic mitral surgery. Superior precision and maneuverability may add some technical value over non-robotic techniques. Technical benefit may be more prominent in complex cases, especially the MAC and the redo cases maybe. A limited data suggests that robotic technique may offer better outcomes and faster recovery. There are challenges like the cost and learning period, but they can be mitigated with investment in training and infrastructure. And multidisciplinary practice may be more feasible during the establishment. And at the last part of my speech, I would like to invite you to submit the abstracts for the ISMICS. It will be in Istanbul for the next year, and the deadline for the submission is next week. So thank you so much.